Usually, when a fire alarm goes off in the building, you expect to see smoke.
Right. I mean, you'd smell it, you'd look around, maybe see some flames.
Exactly. It's just basic cause and effect. The fire department knows exactly where to aim the hose. But imagine standing in a room and the alarm is absolutely blaring in your ears. It is completely deafening. But when you look around, the walls are just, well, they're pristine.
Yeah, there's no smoke anywhere, no fire.
Right. It creates this overwhelming sense of disorientation.
Yeah.
Because your sensory input is screaming that there is an emergency, but the visual evidence completely contradicts it. You're left entirely in the dark about how to actually fix the problem.
And, when we step into the world of women's health, specifically regarding chronic pelvic and vulval pain, that is the exact agonizing scenario that patients and clinicians are frequently navigating.
Which is why we're jumping straight into a massive stack of sources today. We've pulled together some really comprehensive clinical guidelines for this deep dive.
Yeah, we're looking at documents from the British Society for the Study of Vulval Disease, the Royal College of Obstetricians and Gynecologists, and various standardized medical pathways.
And the clinical literature here is incredibly dense, but, mastering it is crucial for you, the listener,
Yeah.
especially if you're navigating these systems.
It really is. I mean, we are looking at a symptom, severe vulval pain, that affects somewhere between 8 to 15% of women at some point in their reproductive lives.
That's a massive demographic.
It's huge. And they're dealing with a condition that causes profound physical distress, sexual dysfunction, and, quite frankly, intense psychological isolation.
So our mission for this deep dive is to figure out how clinicians actually solve this diagnostic puzzle. Specifically, we want to understand how they differentiate between a chronic inflammatory skin condition known as a dermatosis and a localized precancerous lesion called vulval intraepithelial neoplasia, or VIN.
Right, doing all this during a standard pain assessment.
Okay, let's unpack this. Because the reality of how these symptoms overlap is it's staggering. If you're hearing this and thinking about your own health, or if you're just fascinated by medical mysteries, the stakes here are really wild.
They absolutely are. Misdiagnosing a severe inflammatory condition as, say, a stubborn yeast infection, it leaves a patient in agony for months or even years.
Yeah. And on the flip side, mistaking a localized VIN lesion for a run-of-the-mill skin rash means missing a critical fleeting window to prevent the development of invasive vulval cancer.
The clinician is essentially walking a diagnostic tightrope every single time a patient presents with these symptoms.
But before we can even begin to pull apart the differences between an inflammatory rash and a precancerous lesion, we really need a baseline. Like, how does the medical community actually categorize this kind of pain?
Right. If you can't see the fire, what do the guidelines actually tell a doctor to do?
Exactly. Where do they even start?
Well, the turning point for this was the 2015 classification by the International Society for the Study of Vulvovaginal Diseases. They completely overhauled the framework.
Okay, so they changed how we look at it entirely.
They did. They divided vulval pain into two very distinct categories. The first category is pain caused by a specific identifiable disorder.
Which would be what exactly?
That covers your infections, your inflammatory conditions, allergic reactions, and neoplasms, which are abnormal tissue growths. In this category, there is a visible clinical sign. You can see tissue damage.
So the fire that is actively causing the alarm to ring.
Precisely. Now, the second category is vulvodynia. And the guidelines explicitly define vulvodynia as vulval discomfort, which patients most commonly describe as a severe burning sensation that occurs in the complete absence of any relevant visible finding.
Wait, complete absence?
Yes, no visible findings and no specific identifiable neurological disorder.
Wow, the invisible fire. It's fascinating that the diagnosis of vulvodynia fundamentally relies on the lack of visual evidence.
It is a diagnosis of exclusion in many ways. And to understand how it functions, we really have to look at its subsets. Vulvodynia can be generalized, meaning the burning sensation affects the entire vulval region,
Right.
Or it can be localized to one specific anatomical point. The most common being vestibulodynia, which is severe pain isolated to the vestibule right at the entrance to the vagina.
The sources actually mentioned a very specific way doctors test for that localized pain. It involves a cotton wool bud, which honestly sounds incredibly low-tech for such a complex issue.
It is super low-tech, but it is a highly calibrated neurological assessment. The clinician uses the tip of a simple cotton swab to apply very gentle, standardized pressure to specific focal points.
Like around the vaginal opening and the clitoris.
Exactly. They are systematically mapping the pain pathways. In a patient with localized provoked vulvodynia, the touch of a soft cotton swab, which would feel like absolutely nothing, triggers a severe pain response.
That's wild. So the nervous system is basically overreacting. It's taking a totally harmless stimulus, like, wearing denim or using a tampon, and interpreting it as a massive tissue injury.
That's exactly what's happening.
The alarm system is malfunctioning because the wiring itself has become hypersensitive.
If we connect this to the bigger picture, the moment a clinician performs an examination and actually sees structural changes, redness, plaques, thinning skin, the entire diagnostic algorithm shifts.
Because we're no longer in the invisible fire territory.
Right. We are no longer dealing with the invisible pain of vulvodynia. The presence of visual evidence means we are now hunting for a specific disorder. Which brings us to the first major category of visual mimicry, the inflammatory dermatosis.
Right, let's explore those visible fires. Because when the immune system decides to attack the skin of the vulva, it causes absolute chaos.
It really does.
And instead of just reading down a list of skin conditions, let's look at how they actually change the architecture of the body. Because the one that really dominated the clinical guidelines is lichen sclerosis.
Yeah, lichen sclerosis is a highly aggressive chronic inflammatory condition. And at a cellular level, it is lymphocyte-mediated.
Okay, remind us what lymphocytes are doing here.
Sure. So your lymphocytes are a type of white blood cell, right? A core part of your immune system. In lichen sclerosis, for reasons we still don't fully understand, an army of these white blood cells gathers just beneath the basement membrane of the skin.
And they just start attacking healthy tissue.
Yes. The body essentially goes to war with itself. And the visual result of that cellular war is really striking. The guidelines describe the skin becoming intensely itchy, pale, and remarkably thin.
I think the source has compared it to crinkled cigarette paper, which is such a vivid image.
It is, but the thinning is just the beginning. The constant chronic inflammation fundamentally destroys the underlying architecture of the vulva. The continuous tissue damage and scarring lead to terrifying anatomical changes.
Yeah, things like clitoral burying, where the prepuce or the hood actually scars over and physically traps the clitoris beneath it.
Or labial fusion, where the inner lips fuse completely together.
It's awful. It's not just a rash. It's a literal structural remodeling of the anatomy. And honestly, the most alarming part is that lichen sclerosis carries roughly a 4% risk of eventually developing into squamous cell carcinoma.
And that underlying risk of malignancy changes how aggressively it has to be managed. But now contrast that with another condition from the sources, lichen planus.
Right, the erosive variant mostly.
Exactly. We see the erosive variant most often in these patients. It doesn't typically cause that crinkled, thinning skin. Instead, the immune attack causes raw, incredibly painful, weeping erosions that destroy the top layer of the tissue.
And unlike lichen sclerosis, which usually stays on the outside skin, the sources note that lichen planus loves to dive deep into mucosal surfaces, like extending far into the vagina.
Yeah, and there was also a massive diagnostic clue mentioned for this one. If a doctor suspects lichen planus on the vulva, they are instructed to immediately ask the patient to open their mouth.
Wait, check the mouth for a pelvic pain issue.
Yes, because lichen planus is a systemic inflammatory condition. It doesn't just target the pelvis. It frequently attacks the oral mucosa in the exact same way, causing identical erosive lesions inside the cheeks and on the gums.
That is wild. Your mouth proving what's happening to your pelvis.
Discovering those mouth lesions is a massive shortcut to confirming a diagnosis that might otherwise require, invasive testing down below.
Okay, so beyond those autoimmune attacks, we also have to consider external damage, right? Like eczema or dermatitis.
Yeah, which can be atopic, meaning a systemic allergy, or contact-based, where the skin is reacting to irritants, things like harsh soaps or synthetic dyes in underwear.
And the mechanism to focus on with eczema is lichenification, which is basically the physiological result of the itch-scratch cycle.
Exactly. The initial allergic reaction causes a profound itch. The patient inevitably scratches, and the skin interprets that constant mechanical trauma, the scratching, as an attack.
So it tries to defend itself.
Right. Its defense mechanism is to rapidly thicken, becoming leathery, scaly, and hyperpigmented to shield itself.
Which, in a cruel biological joke, makes the skin feel tighter and actually itch even more.
Ew.
Oh, and we should briefly mention psoriasis too, right? Less itchy than the others, usually bright red, glazed, well-demarcated, and often involves the natal cleft.
Yes, that's another important one on the differential.
Okay, so if these conditions are intensely uncomfortable and literally structurally change the tissue, how do we distinguish between an angry skin condition and something that is actively turning into cancer? Are the symptoms really that different?
Well, the chilling reality is that visually, you often cannot. The symptoms of severe inflammation and the symptoms of pre-malignancy are frequently identical.
Which brings us to the ultimate mimic vulval intraepithelial neoplasia, or VIN.
Right. We are talking about a pre-malignant condition here. The cells in the very top layer of the skin, the epithelium, have begun to mutate and grow abnormally.
But crucially, they are premalignant because they have not yet broken through the basement membrane, right? Like the floor of that top layer of skin.
Exactly. Once they breach that floor and invade the deeper tissues, it is officially classified as invasive cancer. So the goal is to catch VIN while it is still contained above that membrane.
And the guidelines divide VIN into two entirely distinct types. Understanding the difference here is critical for you listening because they operate on completely different biological engines.
They really do. The vast majority, about 95% of cases, is the usual type, sometimes called UVIN or high-grade squamous intraepithelial lesion.
And UVIN is a virally driven process, right?
Yes, it is almost entirely caused by high-risk strains of the human papillomavirus, predominantly HPV type 16. The virus basically hijacks the cellular machinery of the skin cells, forcing them to replicate abnormally.
Because it's an STD-related viral infection, we typically see UVIN in younger demographics, usually women between the ages of 35 and 49.
And it is frequently multifocal, meaning you will find multiple separate lesions popping up across the vulva simultaneously.
It's also heavily linked to smoking and immune suppression, which makes sense. If your immune system is occupied or weakened, it just can't clear the virus.
Right, but that's the 95%. The other 5% is the differentiated type, or DVIN. And this is where the mystery really deepens, because DVIN has absolutely zero connection to HPV.
Zero.
What's fascinating here is the insidious origin of DVIN. It is directly, causally linked to the chronic inflammatory dermatosis we just discussed, especially lichen sclerosis.
So the inflammation itself is the trigger.
Yes, we see this primarily in older postmenopausal women who have been battling chronic inflammation for years. And while the viral UVIN takes a relatively long time to progress to cancer, DVIN is highly aggressive.
Yeah, the clinical data from the stack points to a 50% chance of DVIN progressing to invasive squamous cell carcinoma within 10 years if it goes untreated.
Half of all cases progressing within a decade is an astonishingly high risk profile for a premalignant lesion.
Wait, hold on. 50%. If it is literally a coin flip that this lesion turns into cancer, why wouldn't a doctor just immediately surgically remove every single abnormal patch of skin they find down there? Why even mess around with topical creams or wait-and-see approaches?
Because you have to consider the specific anatomy we are dealing with. Surgical excision of the vulva carries severe, life-altering morbidity. We are talking about permanent scarring, devastating loss of sexual function, chronic nerve damage, and severe psychological trauma.
Oh, wow. Yeah.
You cannot indiscriminately cut out tissue based on a visual guess that a rash might be a DVIN. The treatment itself is too destructive.
You need absolute proof before you bring a scalpel into the equation. But finding that proof is incredibly difficult because the symptoms of both types of VIN, burning, severe itching, soreness, and those raised plaques that can be red, white, or pigmented, they are indistinguishable from the symptoms of lichen sclerosis or severe eczema.
The overlap is near total. And to complicate the diagnostic picture even further, the guidelines note that up to 20% of women with VIN are completely asymptomatic. They feel absolutely nothing.
It's like trying to tell if a crack in the wall is just peeling wallpaper, the dermatosis, or a collapsing structural foundation, the VIN. From the outside, they just look like a crack.
That analogy perfectly captures the danger. The inflammation of lichen sclerosis is the chemical reaction causing the rust. The chronic cellular turnover and damage actually drive the DNA to mutate.
The clinician cannot rely on the naked eye to determine if they are looking at a surface scratch or structural rot.
No, they can't.
So what does the ultimate assessment look like? How do they safely navigate this without doing unnecessary surgery, but also without missing a 50% cancer risk?
It requires a layered, highly structured investigative protocol. A standard visual inspection is useless here. Clinicians start with a forensic pain history, pinpointing exact onset, triggers, and the specific quality of the pain.
And they must also take a psychosexual history, acknowledging that sexual pain creates a massive psychological barrier that really has to be addressed alongside the physical symptoms.
Absolutely. The sources also heavily emphasize testing for external irritants. They note that anywhere between 26 to 80% of women presenting with these overlapping symptoms have a positive patch test.
80%. That's huge.
Yeah, patch testing is a brilliant tool for eliminating variables. By exposing the patients back to a grid of common allergens, fragrances and cosmetics, preservatives and topical creams, specific fabric dyes, the clinician can definitively isolate a contact dermatitis.
Because if the patient is just allergic to their laundry detergent, removing that trigger solves the problem without any invasive procedures.
Exactly. But even with a perfect history, magnifying tools like a vulvoscope and allergy testing, you still can't see the actual DNA of the cells to know if they are mutating.
Which brings us to the definitive tiebreaker.
The biopsy. Taking a small physical sample of the tissue to examine under a microscope.
And the clinical guidelines are incredibly rigid about when a biopsy is absolutely mandatory, right?
Yes. While many simple dermatoses can be diagnosed clinically and managed conservatively, a clinician must biopsy if there is a distinct raised mass. They must biopsy if there is an ulcer that refuses to heal.
Or if the architecture of the tissue is actively altering and destroying normal anatomy. But the most critical trigger for a biopsy mentioned in the pathways is a failure to respond to first-line treatment.
That is the most common pitfall. If a doctor diagnoses suspected lichen sclerosis and prescribes an ultra-potent topical steroid, that steroid suppresses the local immune system and stops the inflammation.
Okay, so the fire gets put out.
Theoretically, if the patient returns a month later and the itching is still severe and the plaque hasn't changed, well, that is a massive red flag.
Because if it was just an inflammatory fire, the steroid hose should have put it out. The fact that it didn't means the fire is being fueled by something else.
Yeah, precisely. Failure to respond to standard medical therapy mandates a biopsy because you have to rule out neoplasia. Once that tissue sample goes to the pathology lab, the scientists have incredibly sophisticated tools to look at the cellular machinery.
Yeah, they use immunohistochemistry markers to basically paint the cells and see what's broken.
We're talking about specific proteins that act as cellular alarms. The sources specifically mention two markers, P16 and P53.
Okay, break those down for us.
Think of these markers as internal cellular spell checkers. If the pathologist applies a stain and the tissue lights up for P16, it indicates that the human papillomavirus has hijacked the cell cycle.
So the presence of P16 strongly confirms an HPV-driven process, locking in a diagnosis of UVIN.
Exactly. But the other one, P53, is arguably more important here. P53 is famously known as the guardian of the genome. It's the factory quality control inspector.
So if a cell's DNA gets damaged by the constant inflammation of lichen sclerosis, P53 is supposed to step in.
Wait, right. It stops the cell from dividing until the DNA is repaired. But if the P53 gene itself mutates and breaks down, the quality control inspector is dead. The cell begins replicating with all its errors, which is the literal definition of cancer.
Yeah.
If a pathologist sees abnormal P53 staining in a biopsy, it points directly to the highly aggressive deviant.
Finding that out completely fractures the treatment pathway. If the biopsy proves you are only dealing with a severe dermatosis, the treatment remains medical. The goal is symptom suppression.
Right, you use deep emollients and carefully tapered topical steroids to force the immune system to stand down, stopping the architectural destruction.
But if that biopsy reveals VIN, you pivot immediately to eradication. You cannot soothe premalignant cells. You have to physically remove them before they break through that basement membrane.
This usually means local surgical excision, literally cutting the lesion out with clear margins. In some very specific cases of UVIN, they might use a topical immune-modulating cream called imiquimod,
which essentially stimulates the patient's own immune system to attack and destroy the viral cells, right?
Yeah. But regardless of the method, eradication is the only acceptable endpoint. And because both UVIN and DVIN have alarmingly high recurrence rates, these patients are locked into rigorous long-term surveillance,
requiring follow-up examinations for at least 5 years. So what does this all mean for you, the listener? To sum up this incredibly complex journey, we started with the baseline of vulvodynia, where severe pain exists without a single visual clue.
We moved into the intense, structure-altering world of inflammatory dermatoses where the immune system attacks the skin.
Right. We exposed the premalignant mimic, VIN, showing how chronic inflammation literally causes the DNA to rust and mutate into aggressive lesions. And finally, we looked at how clinicians use patch tests, failed steroid treatments, and mandatory biopsies looking for broken cellular spell checkers to separate the rash from the precancer.
The clinical logic required to safely navigate that overlap is phenomenal. However, if we look very closely at the most recent research tucked away in our sources, this raises an important question about everything we just discussed.
Ooh, I love a curveball. What did you find?
We spent the very beginning of this deep dive establishing the absolute baseline rule of vulvodynia, right? It is defined by the complete and total absence of visible inflammation. No clinical signs of an acute inflammatory process.
The invisible fire. The pristine room with the blaring alarm. That is the foundational definition from the 2015 ISSVD guidelines.
Well, recent cellular theories on unprovoked vulvodynia are starting to fracture that foundational definition. Researchers recently isolated fibroblasts, which are the cells that build the structural framework of human tissue, directly from the vestibules of patients suffering from severe vulvodynia.
Wait, okay, so they took the cells from the exact area that was burning, even though the skin looked completely normal to the naked eye.
Exactly. And when they examined these fibroblasts in the lab, they discovered that they were hyperreactive to pro-inflammatory stimuli. More importantly, these seemingly healthy cells were actually producing massive, copious amounts of pro-inflammatory mediators,
Wait, really? Like what kind of mediators?
specifically chemicals known as interleukin-6 and prostaglandin E2.
Hold on. Those chemicals are the biological messengers that scream at the immune system to trigger inflammation. So you're saying that even though the skin looks perfectly healthy and normal under a doctor's examination light at a microscopic cellular level, an inflammatory fire is actually raging.
The cellular machinery is churning out inflammatory signals, which forces us to critically evaluate the guidelines. If intense localized inflammation is happening at a microscopic level, even when the tissue looks completely fine, is the dividing line between an invisible pain syndrome and a visible dermatosis actually much blurrier than medicine currently admits?
That is mind-bending. It implies the alarm system isn't malfunctioning at all, it's functioning perfectly. It's just detecting a fire that is burning on a cellular level, too deep and too microscopic for our current clinical tools to see. We aren't dealing with a hallucinated fire, we're just lacking the magnifying glass to see the smoke.
It completely reframes how we should look at pain.
It really does. That is absolutely something to ponder long after you finish listening today. Thank you for joining us as we navigated the intense, high-stakes overlap of vulval pain assessments. Keep questioning the established guidelines, keep digging into the cellular mechanics, and we'll see you on the next deep dive.